Yes.
Good evening, all of you.
A very good evening and welcome everyone. I, Dr. 𝗕𝗥𝗘𝗔𝗦𝗧, on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for today's discussion. On the occasion of Breast Cancer Awareness Month, Voice of Healthcare, in association with AstraZeneca, has taken an initiative to bring together the experts and speakers for the episode 1 of Take It Off Her Chest panel discussion today, which aims to know the importance of early detection of breast cancer. With this discussion, we shall also dive into understanding the signs, symptoms, facts, and myths around breast cancer. So, I would like to commence this session by introducing our eminent speakers. Dr. Seema Sharma, Head of the Department of Obstetrics and Gynecology, Daffodils by Artemis, Jaipur. Welcome, Dr. Sharma. Dr. Raja T, Director, Medical Oncology, Apollo Hospital, Chennai. Welcome, Dr. Raja. Dr. Manasi Shah, Consultant Medical Oncologist, HCG Hospital, Ahmedabad. Welcome, Dr. Shah. Professor Dr. Anita Ramesh, Cancer Specialist, Senior Consultant, Medical and Pediatric Oncology, 𝗕𝗿𝗄𝗏 Medical College and Hospital, Chennai. Welcome, Dr. Ramesh.
Yes, a very good evening to everybody.
Dr. Vivek Belathur, Senior Consultant, Medical Oncology, Fortis Hospital, Bannerghatta Road, Bangaluru.
Thank you.
Welcome, Dr. Vivek. Dr. Senthil Rajappa, Head Medical Oncology, Indo Hospital, Hyderabad. Along with sharing his views, Dr. Senthil will also be moderating today's session. So without further ado, over to you, Dr. Senthil.
Good evening, everybody. Thank you so much, Dr. Ritika, for that very kind introduction. I want to thank all of you and Astra for putting us up here today to educate public about this disease. What are the methods for early detection? What do you do if you find a lump in your breast and so on and so forth? I believe this is a series of programs that you're going to have. And this is part 1 or the first episode of this series. So just to set the context, let me start with some numbers. In 2020, there were 1.78 lakh women diagnosed with breast cancer. That's sad. But the worst part is that just over half of all of them died because of this disease. And I think that's the worst part of the whole thing. If you're born in India, you 1 among 9 women are likely to get breast cancer. 65% of all of them will have disease that is either large but locally present. It's not spread to other parts of the body. About 20%, 25% are likely to have disease which is spread to other parts of the body, which means typically incurable. And that's the sad part. Now, the best way is to prevent oneself from getting this disease at all, or even if one gets it, it should be picked up as early as possible so that with the minimal treatment, one can have a high likelihood of cure. So in order to find out what we should be doing to get to this goal of finding out things early, we have a panel of very senior, well-read, eminent oncologists and an obstetrician gynecologist who will answer some of the questions that we have designed for today's meeting. So let me first start with Dr. Manasi. Dr. Manasi, what's the overall prevalence of breast cancer in India? Is there any difference in the incidence of breast cancer in terms of geographical locations in India? If yes, what do you think is the reason for this? Dr. Manasi, the first question goes to you.
Good evening, everyone.
I think, as you said in your introduction, Dr. Senthil, in terms of the incidence of breast cancer, what we have in terms of statistics, about 2 lakh women newly diagnosed with breast cancer in 2020. If we were to talk about the prevalence, I think it was in the 2016 statistics, around 5 lakh women at that point of time were undergoing treatment for breast cancer, and majority of them were for advanced disease. So we do have in India the population-based cancer registries. I think there are about 28 of them. And based on these registries, the highest incidence of breast cancer was in Hyderabad, Chennai, Bangalore, and Delhi. Uh, so Hyderabad, I think, as a city, had the highest number of breast cancer cases registered. And if we look at these, I think breast cancer is more of a disease in the urban areas. There's, of course, lifestyle modifications that we attribute to urban areas, such as delayed age at first birth, probably
We'll come to
inadequate
that in a moment,
breastfeeding.
Dr. Mansi.
So,
Is
yeah.
there any
So,
difference? Is there any reason for the difference in incidence across geographies, or you think it's just that one
so
place
I
is
think
reporting the disease better? Is it just actual, or is it apparent?
it's hard to say. I don't think we have good epidemiological studies to kind of tell us if there's any particular reason for those cases to be concentrated in certain areas.
Compared to, let's say, the US, where the incidence is extremely high, how much is the difference between, let's say, a country like India or a third world country compared to the US in terms of incidence of breast cancers?
So
You
I
said
think
52 per 100,000 in Hyderabad. You're absolutely right. That's the highest in the country. Let's say in a country like US, the incidence is nearly about 130 to 150 per 100,000. So the incidence of disease is lesser in our country, but it's slowly and
correct.
steadily going up. But in terms of the absolute numbers that you will see, it is mind-boggling in our country compared to what you would see in the rest of the world. So that's very important to keep in mind. Dr. Mansi rightly pointed out regarding the prevalence. It's the total number of people who are living with disease. It's not the number of people per 100,000 who are diagnosed every year. It's the number of people who are living with disease. That's the prevalence, and that's constantly also increasing over time. So thanks, Dr. Mansi, for those very nice answers. My next question is to Dr. Raja. So, what are the breast cancer screening tests that are available in India?
Good evening, Dr. Senthil, and good evening, everyone. What are the tests available in India? Everyone is very familiar with the term called mammogram, mammography, and the mammogram. So, mammogram machines are now available all over the country, and so much so that there are very, very well-minded NGO groups which have done, mobile mammogram units. So they have really, really taken it forward. So just to answer your question, mammogram is the gold standard for screening test. But in mammogram itself, you can call it as a simple X-ray mammogram, which is technically a 2D mammogram. Then we have what we call a mammogram. We have a 3D version. We have a tomosynthesis, and these are the advancing technologies. And now the 3D versions and tomosynthesis is slowly replacing the previous conventional mammograms that are available. So this is a very, very important screening tool. And another screening tool which we need to mention is the MRI, MR mammogram. It also needs a dedicated coil to do the screen. Now, with regard to screening, quickly, screening can be approached in two different ways. One, age appropriate screening, and again, risk appropriate screening. That's very important knowledge we need to pass on. Age appropriate screening is that generally we don't consider that screening is useful in women below 40, and then we look at the age group of 40 to 49. There are significant discussions there, but most of the groups, including the American Cancer Society, has settled down at the age of 45. They start recommending screening. Age 50 to 70, definitely everyone agrees that screening should be recommended, and above 70 up till 75, most society most groups would recommend, but beyond 75, it's individualized. And with regard to the type of screening, also, most of them recommend annual screening, but some of them recommend that you can screen individuals once in 2 years. And this recommendation is purely for people whom we consider as normal risk. Most women are normal risk women, so that's the recommendation. But we need to also mention about something called higher than normal risk, or when there is a family history, or there are certain genetic syndromes. These are grouped as high risk. In high risk, actually, the recommendation would be to go for MR mammogram, annual MR mammogram in the same age group. So that's the message we need to pass on. And these are screening tools that are widely available in most hospitals, including most of the tier 2 cities. And as I've told you, there are very, very good groups which have taken it forward by trying to improve the access of such a screening tool to most of the women in our population.
Excellent. So the standard one is a mammogram. You also have an MRI, as Dr. Raja rightly pointed out. This is done every year or every other year. And depending upon your risk of developing this disease, you may need more frequent screening compared to what is conventionally done. So that's what you should understand from this. Dr. Anita, how frequently should breast cancer screening be done? Dr. Raja has partly answered that question, but can you elaborate on that?
See, if you the three most important things for breast cancer screening, which is the breast self-examination, which the woman usually does on her own, preferably to be done on the 5th day of the menstrual period. It's in the look and feel, two of methods: standing position, sitting down position, lying position, and to be done from your any age to continue on the 5th day till you're menstruating. Once you stop your menstruation, it can be done on the first day of any month and to continue. Next is it is done on a monthly basis. Next, another thing is that physical examination of the breast, which is suggested if you are keeping your screening age as 40 or 45, it is to be done monthly, to be done yearly with the physician. Point number 2. Point number 3, regarding mammogram. If you are in an average or normal individual, 40, 45, little bit of debate in India. I would rather prefer to start it at 40, do it in an yearly fashion. 40 to 50, 55 to 60 is the age where we are looking into these breast cancer. The risk decreases after little 60 beyond, and you can increase the frequency and make it once in 2 years. Coming to the high risk individual, it starts at the age of 30, particularly those who are BRCA1, BRCA2 positive, family history of cancer, mother, sister, blood relation, Lee-Fraumeni syndrome, or you had a radiation to the chest wall due to any other reason or any other cancer. They all form under the high risk. Screening starts at the age of 30, where MRI of the breast comes into the play. Breast self-examination is there, and physicians examination also falls apart, can be done 6 monthly, 12 monthly. Please start at the age of 30. So with risks adjusted, we do the screening, and that's how the frequency goes.
Okay, so for standard risk, for the average lady, it's annual. For some high risk, it might be more frequent, once every 6 months, a mammogram once, and an MRI the next time, and so on and so forth. Let me go to the next question. This is for Dr. Vivek. Dr. Vivek, we've been discussing mammogram, frequency of screening, risk, and so on and so forth in great detail. Why is it that we should be doing this? What's the importance of picking up this disease early?
Thank you, sir. So I think the importance of breast cancer screening lies in its outcomes of these patients when they are detected early and treated accordingly. So all of these screening programs, screening tests have shown a decreased mortality rate. That is, patients dying much less compared to those who are detected at a later stage. So, so these screening tests, particularly mammogram, has proven to be very good in terms of making these people survive much longer than those who have not been detected. So that is the most important thing. So unfortunately, in India, we do not have these screening programs as a policy. But in the rest of the world, like in the developed countries, particularly in US, Canada, Europe, and Australia, where this has been a standard national program, they have already seen decrease in the mortality of breast cancer, whereas in India we are seeing increasing trends still, because we have not adopted that. And what happens is, when the breast cancer is detected in its early stages, the treatment will be simple. It's not complicated, and the outcomes are much better. So that's the reason why we should concentrate on early detection through mammogram programs, screening programs.
Excellent. So we need to reiterate the fact that when you're doing a mammogram, you will pick up a very early cancer. You might also pick up precancerous conditions,
Yes, sir.
where once you treat these precancerous conditions, the chance of a cure is almost 100%. Even in the early stage cancer, with today's available therapies, majority of patients, when I say majority, I'm talking about more than 95% of all patients who are picked up in stage 1 are today cured of their disease. So that's very important. Dr. Raja, sir, can I ask you this question? Uh, is every lump that is picked up in a mammogram a cancer? What's the likelihood of missing something, and what's the likelihood of over-diagnosing something on a mammogram? I think that's very important to understand.
Every lump that's picked up on the, every lump that is either physically felt, first of all, is not a malignancy. That's something that we need to talk about. In the same context, I just want to touch upon. I will talk about the lump, but I want to touch upon, since it's related, self breast examination.
Oh yes, that's also your question, so you can answer that, sir.
So there are interesting thoughts about self-breast examination.
Correct.
One thing is very clear. Breast examination can be a self-breast examination, or a physician, or even a trained personnel. It could be even a well-trained nurse. That's known as clinical breast examination. Now, there is a very good understanding about this in a mass population basis. Clinical breast examination alone is not to be recommended as a screening tool, but clinical breast examinations usually as an add-on, adjunct for with the mammogram as a screening test. I'm just talking about screening test.
Yes.
Similarly, self-breast examination, which for the past decades we have been advocating, now there is enough data to say that self-breast examination is not to be recommended as a screening tool, even though self-breast examination is now, I think the word to qualify self-breast examination is that it is more of self-breast awareness, and
Exactly.
or women become more aware, and they won't even stylishly coin the term called you are empowered. Women are empowered with self-breast examination. Self-breast examination is not to be recommended as a screening tool. In fact, it actually leads to higher. There is an higher positivity, false positivity, and there is increased number of biopsies due to that, and it does not translate into impact into any of the early detection or survival. So, self-breast examination is to be actually slowly dropped out of as a screening tool. But of course, many societies still talk about self-breast examination more as a phenomenon of self-breast awareness. So, taking that context, every lump is not malignancy, and we can say that two-thirds of the lumps, whichever is felt by women, is not malignant. It's actually a benign disease. So, I would say it's a very rough number, but only one-third of the lump that is felt is finally a malignant lump. And there are some typical characteristics that can be attributed. You can look at the skin, you can look at the um, dimpling, and then changes in the skin character, or the classical pure orange, and then in retraction of the nipple, and associated color changes of the skin, and red or inflamed, and discharges with chemical, and associated lump in the axilla. So those things qualify a lump better in the direction of a malignancy. That's how clinically you make the judgment. So the broader message, the short answer to your question is, not every lump is malignant, and it should be probably brought to the attention of a physician
Absolutely.
who are trained in breast examination, and they will take it forward. So that will be the best advice.
Correct. So all lumps that are there on a mammogram, in fact, majority of lumps that are there on a mammogram are unlikely to be malignant. And please remember that a mammogram can also miss a malignancy because it has its own limitations like any other technique. So we've come to this controversial issue of breast self-examination. Vivek in his earlier answer clearly said that the reason for screening is to save lives. That's very important. It's a very important point that he made. Dr. Raja is absolutely right that breast self examination is not something that should be recommended as a standalone screening tool. And he also made the point saying it increases the awareness of the lady towards her breast and what could happen, what changes can happen, and so on and so forth. So, Dr. Mansi, uh, is it still relevant in a country like India that you should still teach, young women or even adolescent children about breast self-examination and so on and so forth? In a country like India, do you think it makes sense to educate them about this so that, though, as rightly pointed out, many of those lumps which happen around the menstrual age group, adolescents, are unlikely to be cancers, but it increases awareness. And at a later stage, if you find something, they are more likely to get a mammogram done, go to the hospital. So, is it possible that you're actually downstaging? We started by saying 65% are locally advanced, which are big lumps. Do you think that there is some evidence, at least in this country, that you can downstage those by teaching women breast self examination and clinical examination? So, I'm sorry for that very long question, but I needed to set that context so that your answer will be easy for the audience to assimilate. Mansi.
Yes, Dr. Sensor. So, in terms of the self-breast examination, I think we've already discussed that standalone, it is not a good screening tool. But I
Right.
think it helps in two or three different ways. A, it increases awareness. People understand what is normal versus what is not normal. So, we always educate people that if you see any skin changes, any nipple changes, any visible dimpling on the skin, etc., etc. So I think it increases awareness. Secondly, I think it also makes people go to their healthcare providers earlier. So rather than waiting for a fungating mass, that sometimes patients' relatives come and tell us that there was so much of smell and we thought that something is not right, and hence we took our mother or somebody to the doctor. At least that scenario we should not see anymore, I feel. So I think it sensitizes people to access healthcare better. I think that is another important point. And thirdly, I think it also helps women to talk about it. So it no longer is a taboo. If we go ahead and tell people this is how to examine your breasts and this is what is normal, this is not, I think it removes a lot of stigma that is associated with breast health. So that's where I think it's important.
Excellent. So I think you highlighted all the important points very nicely, Dr. Mansi. So I think it's still relevant, though it's not the best recommended technique for cancer screening at this point in time because it makes the lady aware. There is some evidence based on some publications from India that it might actually downstage, uh, and you might be able to pick up this disease a little early, not in the stage that we would like it to be picked up. We'd like it to be picked up in, let's say, 0.5
Stage
centimeters, zero
zero
point
or
0.2
stage
centimeters,
one, yeah.
stage 0 or stage 1. That's what we are talking about when we are referring to screening for breast cancer. The context in which Dr. Mansi is talking about is instead of being diagnosed with a big lump in stage 3, you could be diagnosed with stage 2 or a late stage 1, wherein the likelihood of cure might still be higher than what it is if you were otherwise diagnosed at a later stage. So that's the context in which Dr. Mansi is saying, and I entirely agree with that. So we'll come to the gynecologist, Dr. Seema. Madam, gynecologists are usually the first point of contact in this scenario. So, what is the role of the gynecologist in breast cancer screening, madam?
Yes, sir. Actually, I find the role of gynecologist very important in this whole part because, as Raja sir already pointed out, that the screening should be risk-based as well as age-appropriate screening. So here the role of gynecologist come because these patients mostly it is seen that they come to gynecologist first. So they are the ones who can segregate these patients with their detailed history and examination because examination of breast can be a part of gynecological examination also as they are dealing with the problems associated with lactation, mastitis, and hormonal changes in breast. All of these problems they are taking care of. So they are trained in clinical examination, they are trained in endocrine evaluation, and as well as management of breast abscesses and benign diseases. So they should, as a first point of uh, care, they should take care of all the detailed history taking and the examination and then patient counseling and awareing them regarding the late stage diseases and their complications. As we have seen in the cases of cervical cancer, it was increasing in India, but with the concept of down staging, as you were talking, sir, Senthil, sir, we have brought it down so much so that it is not now increasing, rather in a decreasing trend in India. So the same we want for the CA breast, that we can identify these cases in a very early stage, and along with this, we can have a multidisciplinary approach once we catch up these patients. Because gynecological examination with breast evaluation is very important to catch up these patients in very early stage so that the disease is not progressed, and we know that in stage 1 and stage 2 we can have almost and even not 100%, then even we can have 92 to 97% of survival rate, 5-year survival rate. So I find a robust role of gynecologist in breast evaluation, not only in screening and diagnosis, even managing these patients, having counseling along with a multidisciplinary team, and definitely patient awareness, public awareness.
Excellent, madam. So I think you hit the nail on the head. It's a multidisciplinary approach that will ultimately help us achieve our goals. So since these women are more likely to come to the gynecologist with a breast lump, it's important to educate not only the women, it's also important to educate healthcare professionals, paramedics, and all of them to help women identify this disease early and treat them appropriately and adequately. I think that's a point very well made. Multidisciplinary approach. The next question goes to Dr. Raja. So, what are the risk factors associated with breast cancer? Are there ways of reducing the risk of breast cancer?
Thank you, Dr. Senthil. Generally, we can classify or understand the risk factors as either you know lifestyle related broadly, for a larger audience that would be the relevant thing. Um, and then there are you know risk factors that are associated with the high risk breast situation or high risk um, syndromes and all that. So, with regard to modifiable or lifestyle associated risk factors, I would begin with simple things like age itself is a risk factor because it's a degenerative disease, and then body weight and body mass index, obesity, and particularly it is said that something called central obesity has some relevance, and then diet and high fat diet. I mean, these are all considered as modifiable. Sedentary lifestyles, lack of exercise, and if you had alcohol consumption is also related to increasing risk factors, and this is now a more progressive society, I would say. So obviously that also needs to be brought into awareness. Unfortunately, cigarette smoking is also a possibility. So all these has to be carried across. Other than that, there are some other risk factors like the hormone interaction. So that would be the age at which the marriage, or the age at which classically the first child birth, and then number of children, and then breastfeeding. Breastfeeding is very important because there is enough data to support that the number of children and breastfeeding, at least 1 year of breastfeeding, definitely has an impact in reducing the incidence of breast cancer. And these are modifiable risks. But there are certain non-modifiable risks. Being women itself is one of the risk factor, age as we mentioned. And then there are familial syndrome, family history, and if you are unfortunately carrying some of the predisposing syndrome, it may be relevant to talk about some predisposing syndrome because now there is increasing awareness. We'll just mention some common predisposing syndrome like BRCA 1 and 2 mutated syndrome. Basically, it's a breast ovarian cancer predisposition syndrome. And there are some other syndromes like nephromonia and so on. But I think that will be too technical for the common people. But it is important to be aware that there is something called predisposition and there is something called family history. And other than that, that is a special thing, as was already mentioned. If you had a prior breast lump, and if you had a prior treatment, and if you were one of those patients treated for any other malignancies and had a radiation around the chest, so these are all something important to be aware, and these are long-term follow-up issues of patients who are treated for prior cancers and if they have been exposed to radiation. So these are the things that need to be talked about and considered as important to that subject.
Absolutely. Thank you so much, sir. So broadly, you could divide it to, the modifiable and non-modifiable. I think it's important to reiterate the points that Dr. Raja made as far as the modifiable risk factors are concerned, because that's what, more importantly will interest us. Uh, he did speak about sedentary lifestyles that should be avoided, bring down the likelihood of becoming obese, uh, watch what you eat, exercise adequately and exercise regularly, make sure that you stop smoking, you quit smoking, because that's bad in so many ways. uh, Alcohol should be in moderation because it's also clearly been shown to be associated with a higher likelihood of developing breast cancer. uh, Sir, you said the moment you're born as a lady, your risk starts. There's a question in the box asking, can males develop breast cancer?
Yeah, so women are special. We need to acknowledge that. No question about that. But unfortunately, that is considered as a risk factor. So maybe, as Dr. Mansi said, you need to, and then your bigger question, being self-aware and then reducing the taboo and encouraging the habit of talking to each other. So probably that's what it means. But then your other question is very important. Males can also develop breast cancer, and around 2% to 3% of all breast cancer are actually male breast cancers. So we need to be aware of that. So even men, whenever they see a lump which is not normal, and if they see some changes, particularly if there is a discordance between both the sides, and if there is a persistent lump, they need to definitely reach out to the healthcare provider. And it's also important to be aware of the predisposition syndrome, where there is a family history. That is when men are at a higher risk of developing breast cancer. There are certain other syndromes like if there are some certain drugs, and there are some syndromes associated with testicular failure, basically all related to hormonal influence. Again, those things can predispose men to have breast cancer. So it's very important. Men can also have breast cancer, It is important to be aware, and whenever, again, the same question of taboo is all very important. So you need to break it and reach out to your healthcare provider. Should be an important message.
Excellent. So, guys, if you're listening, don't think you're immune. So you can also get this. So be on the watch out. It's less likely, but it can happen. Dr. Anita, what is the difference between are there difference between the signs and symptoms of breast cancer uh, depending upon the stage? Let's go from no palpable lump at all to something that's ulcerating and fungating. If you can take us through that sequence, it will be great.
Yes, definitely. The signs, symptoms are different for different stages of the tumor. Yes, you are right. Some of them are undetectable, maybe picked up by any routine health checkup, or picked up by you're going for any, even in the COVID periods, we did picked up during the plain CT low dose of the chest some lumps. So they are asymptomatic, a lump picked up. Patient does not know, is taken unaware to get a lump, and she says, I'm absolutely fine and I've never experienced this. So that's the very early stage. Some of these stages, in maybe if you have a orientation awareness and you are a little literate or educated, or you are in the urban cities, then you know how to pick up. As we do this screening, you might be able to pick up small lumps in the breast during your examination and meet the doctor. So small lumps, early stage, can be picked up. And just to tell the viewers, usually in this early stage, you are asymptomatic. There'll be no pain, there'll be no skin puckering or any other thing, just detection of the lump. So, and as the tumor grows, you get into stage 2, stage 3 and 4. Then there'll be a definitely, when you do the palpation of the breast, there'll be a definitely lump palpated. Usually it will be, and I think WHO has 8 to 9 pictures which will help you to find out how it looks like. It can be like an orange, the skin can be puckered, your nipple can be retracted, your breast can be increased in size, your breast can be decreased in size, the breast can be pulled inside also. There may be blood discharge, white discharge from the nipple, and just in very advanced case, the skin may break up, you may have ulceration, you may have bleeding, you may have it's fixed to the chest wall, and you may have lumps in your neck, in your axilla. On very late stage, patients do present with sometime sudden onset of convulsions. They may present with jaundice, with liver mets, brain mets. They may have a fracture, pathological fracture when we pick up, that is a deposit in the bone. They may have spinal compression, suddenness. So this, in an advanced stage, anything can happen, and usually the patient will be very symptomatic, and that gives you takes you to the breast as the primary and other as metastatic site. But definitely in an early stage, you may be taken aware, and and I think all of our practice, we picked up many breast cancer during the last 2 periods with COVID when they did the screening CT. So it differs with stage to stage.
Great. So it's a wide spectrum of signs and symptoms that you can have when somebody has breast cancer. As you know, we started discussing about screening. Screening, you want to pick up a lump that's not palpable at all. When I say palpable, you feel it. So you should be ideally picking up the disease when you can't feel it at all. As the stage keeps increasing, the size of the lump in the breast can keep going up. You could also feel a lump in the armpit, which is very important, especially if you're doing breast self-examination regularly. Those skin changes that Dr. Anita mentioned about are relatively late signs of disease. That means that in the local area, it started increasing in size and involving the skin, involving the structures behind the breast, and so on. And if it is stage 4, you could have signs and symptoms that tell us that it could have gone to the liver, it could have gone to the brain or the bone or lung, and so on. That's stage 4. That's a stage at which the disease is usually incurable. So it's important to pick it up very, very early because that's the stage in which you can treat and be cured most of the time. And that brings us to the question of what treatments are available to treat this disease at an early stage. What are the differences in the treatment approaches between early versus late stage cancer? Dr. Vivek, this is for you. You're muted, Vivek.
I'm sorry. Hope you
Yeah,
can hear me.
now it's fine. Now
Yeah,
it's fine.
sorry. Yeah, I think treatment of breast cancer is very important. If someone is diagnosed with breast cancer, they need not get disheartened because there are a lot of treatment options now. I think we are in a stage wherein we have newer treatment options available now for these patients, and that has brought about the best survival rates, which was not seen before. So there are two, three important things when we talk about treatment of breast cancer. One is the stage of the breast cancer. So stage is determined by doing scans, either CT scan of the chest, abdomen, pelvis, and bone scan, or a PET CT scan. So with these two scans, we will know the exact stage of the breast cancer. It could be either stage 1, 2, 3, or 4. So stage 1 to 3 are called non-metastatic or non-advanced breast cancer, whereas stage 4 is advanced cancer, wherein the cancer would have spread to other organs, different areas of the body from the breast. And the other important aspect when we decide to treat somebody is the hormone receptor status, what we call as ER, PR, and HER2 status. So hormone receptor status is very important determinant when we plan treatment for somebody with breast cancer. So when we come to the treatment modalities which are available for breast cancer, there are three important treatment modalities. One is surgery, the second one is radiation, and the third one is systemic therapy. So systemic therapy consists of four types of treatment in it. The first one is chemotherapy, which is very well known, and then the hormonal therapy. Third one is targeted therapy, also known as anti-HER2 therapy as far as breast cancer is concerned. And then of late we have immunotherapy also. So these are different types of systemic therapies which are available for breast cancer, used in different permutation and combination depending on the stage and the hormone receptor status. So as far as the early breast cancer is concerned, let's say stage 1. So generally, the treatment would consist of surgery followed by radiation, then plus or minus chemotherapy, and then plus or minus hormonal therapy. So in some patients, even in early stage breast cancer, we can avoid chemotherapy if they have lower risk for a disease coming back. So that risk is assessed with certain tests which are now available in India, called Oncotype DX, Mammoprint, etc. So with these tests, we will know whether hormonal therapy, apart from surgery and radiation, is enough for some of these early. These tests tell us that it is high risk for disease recurrence, then we would go on to add chemotherapy. So some of the early breast cancer can actually avoid chemotherapy. For rest, like say stage 2 and stage 3, depending on the hormonal receptor status, they would go on. They go on to receive surgery, radiation, and systemic therapy with whatever the sequence which we decide. So systemic therapy would consist of again chemotherapy, hormonal therapy, plus or minus anti-HER2 therapy if somebody is HER2 positive, and then nowadays we have also started using immunotherapy even in early, not early, but in non-metastatic breast cancers. And then for all advanced or stage 4 breast cancer, I think surgery is not a very important treatment. It is sparingly used or rarely used. And the most important treatment would be, systemic therapy again, which is chemotherapy, plus or minus hormonal therapy, plus or minus, targeted therapy or anti-HER2 therapy. So this is an overview of the treatment of breast cancer, I would say, sir.
Thanks, Vivek. That's a very complicated question, but you made it quite simple. Thank you so much. I think you started, the most important thing is what you started with: don't lose heart. I think it's important to go and meet your physician, because the physician will obviously do all the tests that you rightly pointed out, stage the disease, find out what type of breast cancer it is, and then offer the most appropriate treatments that are necessary for that stage and type. For the audience, you should understand that not all breast cancers are treated alike. The sequence of treatments, the treatments that you need might vary depending very much upon what is your stage of disease and what is the type of breast cancer. I'm mentioning that more than a couple of times because you need to understand that all of these are not the same. So some tests are done in order to ascertain what type it is, and then your physician will say, these are the treatments that you need, and this is the sequence in which you have to do this particular treatment so that you get the best chance of a cure. So thanks so much, Vivek, for making that very simple. Let me come to Dr. Seema. Madam, There are a couple of questions from the audience which I want you to take. Can breast cancer occur in lactating women? That's one question. The second is any of the screening techniques done for breast cancer painful? Can you take both of these?
Yeah, sir. Breast cancer can happen in lactation as well as during pregnancy also. So, if the patient is coming with such a problem, we should keep in mind uh, that it cannot be only a benign or abscess or lacteal problem, but it can be a cancer also. So, we have to be vigilant about it. And the other part of question is the screening procedure, are they painful or not? So
Yes, yes.
is yeah, so they are not so painful, and in case we need to have biopsy, then it becomes painful. Otherwise, mammography, the only thing you have to have is definite position and exposure of breast. And nowadays we are having some screening tools also, which we are spreading knowledge in our menopausal women, because after 40 they should have some awareness, and they should themselves come out for the screening. So as I am associated with Indian Menopause Society, vice president currently, so we have made a module, and in which we are propagating this online gale screening, so they can in this COVID era particularly we promoted it because they can access it online, and they can have idea about their risk, because it incorporates all the things, their race, ethnicity, family history, past history. So at least some idea is there, and they can step forward for further testing if anything there is higher risk or anything uh, alarming is there.
Dr. Senthil, if I
Okay.
may add,
Yes, sir, please.
with regard to your question on any of the screening tests leading to pain, it is important to, sensitize or to make women aware that when we do the mammogram, which is one of the most important screening tools, the breast
Something.
has to be pressed. So that can definitely lead to discomfort. So that has been well known. But it is important to tell them that that is important as part of the technique, because it actually reduces the artifacts, and it actually also reduces the radiation exposure to that particular part and gives clarity and all that. So a discomfort, yes, has to be mentioned, but unless there is an inflammatory breast, or if there are some open raw areas of the skin or nipple, otherwise it is generally a well tolerated procedure. So that probably needs to be sensitized.
Absolutely. I think that those are very important practical points. Also, the two important things, or two or three important things, should I say? One is, the timing of your mammogram itself. Just like we did mention about doing a self-examination in the post-menstrual phase, it's also good to schedule a mammogram during that period rather than the mid-cycle phase when your breast is engorged and it's more likely to be painful and so on and so forth. uh, uh, it also goes without saying that a trained paramedic will be able to do a much more comfortable mammogram for you rather than somebody who is not very well trained. So that's another important thing. And when you're going in for all these tests, suppose you need to have a biopsy, we always schedule the biopsy after the mammogram, because you don't want to have a poke on your breast and then go and have your breast compressed between two plates, which is what they do in a mammogram. So, like in any other test, I think it's important to talk to your physician rather than just walk into a diagnostic center and get this done. Because I will, if we have some time, ask Dr. Raja about genetic screening also. But any screening test, you need to understand the implication of a positive test, a negative test, and so on and so forth before you really go and get this. And as part of that counseling, he or she will also tell you when to get a mammogram, what's the discomfort that you're likely to feel. If you're prepared for what is likely to happen, I think the experience is not going to be unpleasant at all. So it's a question of being prepared for what is coming, and that's very important to keep in mind. Let me go to Dr. Sir. I'll come back to you on the genetic screening. I think we will have some time because you did mention about those genetic syndromes, and with BRCA1 and 2, Angelina Jolie all over the place. I think it's important to give some tips to our audience on what that is all about. So I'll come back to you in 5 minutes exactly. What stigma do you think is associated with breast cancer in our society? And what role can we play as an individual to overcome this? Dr. Anita, that question is for you.
Yes, you are right that it's still a stigma as far as India is concerned. And yes, breast cancer, just in a layman's term, it breaks up families, divorces, it breaks up engagements in the family. We have seen families breaking up for marriages if one of the parents are diagnosed with breast cancer. And people think it is a infectious disease, people think it is also hereditary. Okay, and apart from that, there is an financial implication in this also. And people also have some myths about that breast cancer, why she got. So this variety of myths are present. Some people feel it is not curable, some people feel it is natural method can help you, natural things can help you. And it's definitely a stigma, both financially, socially, psychosocial, sexual, in all aspects. Still India, we have not come out, but yes, we are developing with more of the education awareness. I think people are becoming more aware about the stigma associated with, it's not, should not be associated with breast cancer. And I think as a physician, all of us have to talk to them, and we should have self-help group as well, patient group, as well as counselors who will, and like this is one of the programs I think which brings it to the audience and makes the physician. And we should also have some patients on for discussion. I did attend these type of social media many webinars where we also bring the patient advocate on the board along with the doctors. They do also talk, and this, and again, what is going on, like awareness, social media, talking, group discussion, will help people to tide over these myths and the stigma, and also help the others to come forward and get the treatment. And seeing these survivors, they should have more strength. Yes, we can also fight the disease.
Excellent. Dr. Mansi, Dr. Anita mentioned about patient advocacy and so on. So how do you think patient advocacy can really help us dispel a lot of stigmas that are in and around this disease itself?
So I assume that by patient advocacy, you mean patient survivors or
survivors, support groups, what education they can do. They are living examples of people who've been diagnosed, cured, and they've come back to the society and are living as normal individuals in the society. So how can this help both educate public and also people, and rather patients who are newly diagnosed with this disease?
I think one of the biggest impacts that the patient advocates have is, they do show some light at the end of the tunnel. I mean, when a patient is diagnosed with cancer, they feel that is the end of it, and this is the end of their life. But when they see that at the other end of it, there is a possibility of having a normal life, I think it definitely has a great positive impact. And secondly, it helps them to talk about things more freely. I think as healthcare providers, we are limited with time and resources in terms of how much support we can give. So social support, also in certain aspects, financial supports, they can talk to them about NGOs that can help them financially. And just in terms of support in every which way, social and financial, I think these patient advocacy groups are definitely very helpful.
Excellent. So I think they can help in so many ways to build up the confidence of patients who are newly diagnosed, and also they are living examples of people who have gone through the whole process, conquered this disease, and come out victoriously. So it's very important to have these patient advocacy groups everywhere so that they educate and also fight for the rights of these patients. That's very, very important at the end of the day. Vivek, what important role does the policymaker have in terms of early diagnosis of breast cancer? Do you think setting some protocols can change the current impact or burden of breast cancer in India? What is it that the policymaker can do, Vivek? You're muted, Vivek.
Sorry again. So it brings us back to that, the non-availability of standard screening programs for any cancer, for that matter, in India. Unfortunately, if we have to achieve good outcomes in breast cancer treatment, I think the only way to do is to detect these cancer at the early stages. So that's by screening mammograms. That's very clear. So unfortunately, for various reasons, it's not there in India. Some of the reasons are like the large population, and then the technical challenges, like the availability of these mammograms, then reporting, uniform reporting, then of course common public issues like lack of awareness, lack of willingness, disbelief, taboo, etc. So while these are going to be fixed, I'm hoping that someday the screening programs becomes reality in India also. I think it's our responsibility right now. I mean, doctors, healthcare professionals, everybody, to increase the awareness and to make people come forward and get this done, mammogram testing done for those who are appropriate, those who are of appropriate age. And I guess I think probably the government or the authorities can probably start this mammogram screening programs in a city setting, probably in a major metros, because the availability of these tests is there. Reporting is fairly okay. Then we have awareness and affordability also. Maybe they can start with major cities and then move out is what I think. So I would like to know others' views as well. This is what I think.
We will come to that. So I think the government should play its role in increasing awareness, educate people, make sure that there are as many mammograms available in order to get these tests done, educate healthcare professionals also to make the best use of all the facilities that are available and so on and so forth. So there's plenty that can be done from the government side itself. Sir, quick thoughts on genetic screening, or who should be getting genetic tests to tell us what their predisposition to the disease is.
Thanks, Dr. Senthil. That's a very special question, I believe, because as it connects with the previous few questions that you had. What is the taboo? And then it also talked about stigma and all that. So it all is related to the society and so the negative aspects of the breast cancer. If these negative aspects that can be actually converted into a positive approach, and where we can really improve upon the way we pick up these diseases early and do the best for each one. So that's when this increasing awareness of genetic predisposition and especially genetic risks and genetic screening comes into importance. First of all, whom do we suspect that there is some problem, hereditary or genetic predisposition? I think it's important to mention that not every woman have genetic disease. Not every woman has a hereditary disease, so it need not be tabooed on them, and then their families need not be castigated. So I would say at 20%. Different societies, different countries, it would be anywhere between 15 to 25%, but I would say 20% of all breast cancers have some sort of predisposition. So when do we suspect such predisposition? Whenever we see young women with breast cancer, typically below 45 or maybe around 50, and then in women when they are below 50, but then they have a family history of someone other very close relative has a breast cancer, or some other relative has got other important cancers like ovarian cancer or even prostate cancer, pancreatic cancer, and more than one blood relative. And then we have something called type of the breast cancer, triple negative breast cancer at any age. And we also have some other special affinities, like somebody who has got a very peculiar peritoneal cancers. And if there is a male breast cancer in the family, And now they increase this net by talking about prostate cancer, pancreatic cancer, and all that. So if you have such cancers in the other family members, it becomes important to look at that particular women and look for predisposition syndrome and then offer them screening test. In the screening test itself, then we understand certain predisposition syndrome to be of high risk, meaning they have a high risk to develop breast cancer. Some other syndromes or some other genetic mutations have a moderate risk, and some of them actually have a low risk to develop breast cancer. Among the high risk, it is important to sensitize the society to what we call BRCA syndrome, BRCA 1 and 2 mutation, and that is known as breast and ovarian cancer syndrome, but it can also lead to other malignancies. And there are now genetic tests available to detect these BRCA mutations, and it can be done as simple as with a blood test. We call it as the germline BRCA detection. And then now there are more wider panels to detect other important genes like if you have a ATM or a CHEK2 or a PALB2 and then Lynch syndrome. So this is only to complete the picture. But the most important thing is then to talk about whenever there is a familial predisposition, it becomes important that even men can develop breast cancer. That message has to be conveyed, and a self-awareness and more regular testing, the MRI used as screening, all that becomes important. And you must reach out to your healthcare providers because they can look at the family history and they can construct a possible what we call as a score to see who are at a high risk. There are a lot of scores that are available. Your healthcare provider will be able to put a score on what is the kind of risk that you have, and then offer you such important screening test. The last part about this genetic screening test or genetic assessment is to why it is important, because you need to be aware that we can intervene in a preventive manner. You can intervene with regard to the opposite breast, and you can also offer um, preventive oophorectomies, bilateral selfing oophorectomy, um, if you in appropriate ages. It's not necessary that everyone has to sacrifice the organs, but your healthcare provider will be able to assess what is your risk depending on whether it's a BRCA 1 and 2, what age, and so on and so forth. And the broader message is preventive things can be done. So this is what we need to probably convey as regard to genetic syndromes, genetic testing, importance, and the entire family needs to be tested. That is known as cascade testing. Once you identify one individual, then we can test the index individual, then we can test the other relevant family members. That's known as cascade testing. And then prevention. These are the things that I would like to talk about with regard to your question, Dr. Sam.
Excellent, sir. I think that's again a difficult question to answer, but very well summarized. Uh, Roughly over the board, if you take 100 women, 5% are likely to be genetically predisposed. As Dr. Raja rightly pointed out, in certain subtypes, for example, the triple negative that he spoke about, it could get to anywhere about 20%. So the most important point is that you should assess your risk before getting any of these tests done. Two, make sure that you're counseled adequately before you get these tests done. Don't go over the counter and get all these things done, because you can be in a real mess, both physically, mentally, psychologically, and so on and so forth. And most importantly, if you find something, cascade testing is important, and understand what can be done at an individual level for you to prevent you from getting all those malignancies that may be associated with that particular cancer that you're genetically predisposed for. Very nice. We've come to the end. I just want to ask one more question that's from the audience. Dr. Mansi, can you take this? After having negative tests of regular mammograms for 3 to 4 years, can women discontinue mammography for some period?
So I think up until 60 or 65 years of age, mammograms are definitely recommended. It can be either annually or once every 2 years. I don't think it's a good idea to discontinue them after 3 times, because as we have heard, this is an age-related disease, although it is happening more in young women, but with increasing age, the risk increases. So it is important to continue doing it.
I think you're absolutely right, Dr. Mansi. It's not appropriate to stop doing this test at any point in time. As Dr. Raja rightly pointed out, it could be annual, it could be once every 2 years, but the yield increases as you keep doing it repeatedly. Doing one mammogram is no good. Please understand that. It's not like once in a lifetime, one mammogram and you're done. Please remember that any screening tool becomes more potent as you keep doing it repeatedly, because the pickup rate keeps increasing as you do it successively over the years. So there's no question of stopping it if your mammogram is all right for 3 to 4 years. This is something that we typically see in practice. The lady will come and say, I've been getting it regularly, and then I just missed for the past 2 years, and now I've come up with this. Right? That's not uncommon at all for us to hear in practice. So please don't stop doing it. Dr. Ritika, do we have time, or because the clock shows 1 hour and 6 minutes, 4 seconds. So if you think we should stop, we will stop here. If we have time, there are a couple of questions. Can you help us with that, please?
Yes, Dr. Senthil. So I think we are past.
Okay, so we are past. Excellent. So then I can propose a formal vote of thanks from my side before I hand it over to you. A lovely session as always. Excellent panelists. Thank you all so much for taking these questions very patiently. Some questions were a little complicated, but I thought you were the best to really resolve that complication and make it as simple as possible for our audience. Thanks again for giving me this opportunity to moderate this session. Thanks all again, and let me hand it over back to Dr. Dhiman for the concluding remarks. Thanks so much.
Thank you.
So we are about to end this session. So I would like to thank all the viewers and especially our eminent speakers, to save the time for this wonderful session. So I would like to thank you all, the panel speakers, and especially the moderator of the session, Dr. Senthil. Thank you so much, Dr. Senthil. Thank you so much, Dr. Mansi, Dr. Vivek, Dr. 𝗕𝗥𝗘𝗥.
Thank you
for taking time for this.
Thank you, Ritika. Thank you all.